We need. Hello, hello. All. Hello, and thank you for coming and making a short lunch to listen to this fireside chat on CARDIO4Cities. My name is Pablo Perel. I'm the Senior Science Advisor of the World Heart Federation. I'm very happy we're going to have a half-an-hour discussion here with Dr. Ann Arts. She's the head of the Novartis Foundation, and Professor Jagan Narula, who is the Executive Vice President and full title is Chief Academic Officer at University of Texas and incoming President of WHF. So we're going to be talking about CARDIO4Cities, and this is related with cities and cardiovascular health. And as an epidemiologist, I mean, I can start to put it into context. About 55% of the population lives in cities, and 70% will live in cities in the next 20, 30 years. But as I was coming here, I was thinking I lived at least 10 years in 3 different cities. In Buenos Aires, where I'm from, in London, and in Geneva. And I think we can all connect to that, how living in a city changed our well-being, our life, I mean, our health. It's definitely, I mean, something that we can all connect with. So let's start with a question to you, Jagat. Why cities and an urban approach is important when we think about health, and in particular when we think about cardiovascular health? I think it's working.
Sure. So first of all, thank you very much for including me in this, Pablo. And there's no fireside here, but you're all really welcome to this. And I start with a fireful announcement here that we are now the proud scientific partners of the CARDIO4Cities of the Novartis Foundation. So thank you very much. So thank you, Daniel. Thank you, Jean-Luc. Thank you, the Executive Council and the board for giving us this opportunity. So now, first of all, you just asked me the question, why is the urban approach important? Most importantly, why is the cardiovascular diseases important? So cardiovascular diseases, which are extremely important as a health priority, is because you have the largest killer of mankind, but yet it is completely preventable. We have made many tremendous progresses in the management of the disease, but that has come at an unacceptable economic cost. We know that it affects the quality of life immensely, but the risk factors associated with it and the causative factors, they remain undetected or silent all along. And then it has got the interconnectedness with so many things, so many multimorbidities, as well as with other socio-economic factors. Now, why is the urban approach more important than anything else here? Is because the cities are the hubs of dense population, and with it, they bring multiple lifestyle-related problems, socio-economic problems, which all need to be addressed. Now, one of the most important things, obviously, we discussed it in the morning, is the air pollution. And that, as you can know, that in the city hubs, it is significantly greater. Then we do talk about the lifestyle changes which start to happen in the urban areas, and they promote the sedentary behavior because of the prevalence of desk jobs, because of the convenience of motorized transport, because of the lack of green spaces, in the socio-economically poor zones when there is lack of safety for the physical exercises, all leading to obesity, metabolic problems, hypertension, diabetes, cardiovascular disease, and whatnot. Then you can go to the cities. They do contribute to the mental stress, fast-paced life, the social isolation, and so many other things. So when we go for the urban approach, it is likely to have a much more dividends in terms of the health outcomes.
Yeah, I think when we think about that, it's so obvious that it affects so much our health and cardiovascular health. So, Anne, tell us about CARDIO4Cities. I mean, what about this great initiative?
Yes, thank you. And CARDIO4Cities is a very simple cardiovascular population health approach that has been validated across continents and works very rapidly. And the reason why it works very rapidly is because it is addressing all these underlying factors. It is an intersectoral or multi-sectoral partnership with local governments in the driver's seat. We always build the roadmaps according to local priorities, integrating what is already being done on the ground, and at the same time innovating where it's needed. In fact, CARDIO is an acronym. It stands for every letter has a meaning, and I started with the back. I started with the O, local ownership. And the I is intersectoral collaboration. But let me go back to the beginning. What it really does is really doing what you were mentioning, Jagat, accelerating the detection of people who are at risk for acute cardiovascular events or cardiovascular disease. So accelerating these risks that are still asymptomatic to detect them and promptly manage them properly. So the A is the acceleration and the C is the quality of care, because in each of the cities what we saw is that there's a lot of guidelines, like 150 pages for 5 different guidelines for health workers that are not being read. We simplify and in many places even standardize the treatment for the cardiovascular risks, at least the first line treatment. And that rapidly improved control rates to then lead to reduction of acute events. So in fact, CARDIO4Cities was pioneered amongst others in São Paulo, and we have Dr. Alvaro here in the room, who was our champion for that, and you can ask all your questions to him. But in São Paulo, a city of 15 million people, more or less, we were able in 1 year of implementation to triple the blood pressure control rates. We started with hypertension, now it's expanded to high cholesterol, diabetes and obesity as well. And that tripling in a very well-functioning primary healthcare system was possible thanks to these simple actions on accelerating detection and prompt adequate management of cardiovascular risk. And it translated into a reduction of up to 13% of strokes in 1 year in a population of 15 million people. That's a lot of lives impacted. So that approach now we aim to accelerate and replicate all around the world together with our partners of the World Heart Federation.
Thank you, and I know it's difficult to summarize in few minutes, and I encourage everyone to go to the website and CARDIO4Cities, where you can find a lot of the tools and publications as well, where you publish about your evidence. But as this is a global initiative, of course, one of the challenges is that you're working in very different contexts. And one question I want to ask you, Jagat, as someone who has worked and has experience in high-income countries and also in low and middle-income countries, what are the differences and challenges that you experience when you want to implement evidence in places like India or the US, places that you have experience?
Pablo, these 2 different scenarios have distinct challenges, but you can leverage the unique opportunities in such places. So, for example, if you look at the cities like cities of United States, you'll see that their problems are different, although they have much better infrastructure, healthcare infrastructure. They have access to modern technology. They have got somewhat superior health literacy as compared to the lower income or middle income countries. However, their problems are different. They are the lifestyle related problems, quite like obesity, lack of physical activity, hypertension, mental stress, and all other things. And obviously, you need a very specific, tailored approach with the data analytics, as Anne just mentioned, and then how the care is to be delivered to those communities. On the other hand, when you go to these cities such as in India, there has been a rapid urbanization. And with the rapid urbanization, there come the problem of pollution, overcrowding, but then they still lag the infrastructure. They still do not have access to that kind of modern technology. And we need to address those problems in a very different way. However, we also need to incorporate some of those beliefs that they have or their traditional medicine and all, and put them together, as also the approach in those countries is likely to be more family-oriented, community-oriented, somewhat different than what we see in the high-income countries. So on one hand, that we have challenges. On the other hand, we have significant opportunities, and it is very crucial that we create the tailored approaches to these cities.
And that relates with the O, in a way, of also Cardio Cities, the ownership and engagement with the community, I guess. You said, I mean, the 3 cities you have pilot were São Paulo, Dakar, and Ulaanbaatar. I mean, can you share any experience about the differences when implementing Cardio Cities in those 3 cities?
Yes, thank you, Pablo. It's true. Every city has its specificities. In general, we see that cities everywhere are drivers of population health. Cities get it. They want their population to become healthier. It's easier to have decision-making in a city in an agile way than at a country level. So that's why, on the one hand, we believe in cities. Secondly, the differences, yes, of course. When we started in Senegal, there were no services whatsoever for cardiovascular disease. So we started from scratch, if you may, to introduce that at the primary healthcare level. And that is hugely successful, but it takes a little bit more time. I said São Paulo, we were able to realize the results in 1 year. In Dakar, in 1.5 years. So not too bad. So it also works, even if the situation is very different. What is absolutely key is that you measure well what you are aiming for achieving, that you see how you are doing in terms of having most of your people you expect in the system to have them diagnosed, and then that you see most of those diagnosed getting under control. If you use these data, I was amazed by seeing the similarities between cities. Every city has the same problems. We recently started CARDIO4Cities in Melbourne, the first city with implementing it with the CARDIO4Cities accelerator. And I see the issues were exactly the same as the ones we encountered in São Paulo. It's missing the people who are asymptomatic. They are not detected rapidly enough. So you have a high proportion of people who are not in the system who need treatment. And on the other hand, you lose a lot of people who are under treatment. To keep them under control is an issue everywhere in the world. So the similarities are larger than the differences. The differences can be overcome by introducing the minimum actions that need to be done at the front line level, and then measuring it, obviously.
And yeah, and I like, I mean, in your website and in your documents, you have specific tools for different stages depending where the cities are. And I think also, I mean, the city approach, what I find interesting, I ask you about India, and I know, I mean, India, even, I mean, it's so diverse, and even within India and different cities, you might have very different approaches, and that probably applies to many of our countries. So you were talking about data. So among the different initiatives we have at the World Heart Federation, one of them is the World Heart Observatory. How the World Heart Observatory, you think, can help and complement this initiative on CARDIO4Cities, Jagat?
So data is the life today, right? And this digital support we definitely require for any initiative. Now, the World Heart Observatory is one of the pivotal initiatives of World Heart Federation. And I must thank you and Dr. Fausto Pinto for having started this and having brought us to the level here and the support from our president, Dr. Pinheiro here. The important thing is that this has the soul affiliated with the Global Burden of Disease and the Institute of Health Metrics and Evaluation. And then it is enriched by the authentic data that is provided to us by our members and our foundations, which is properly gleaned, analyzed, and put together for a free access to any and everyone, right? Now, when we talk about the data, why it really becomes important is that for any place, when the CARDIO4Cities type of an initiative or approach or this ambition is initiated in any city, it basically is able to find the areas which are so-called hot areas where my impact should be, which are the areas where the risk factors are more, where obesity is more, where hypertension is more, where is other thing, all the factors put together or whatever else it is. We basically are able to identify the hotspots and tailor the approach to those areas. There is also, it is extremely important that we are able to monitor the trends and the effect of the interventions. And if something is working at some place, and as Anne was just saying, that eventually the problems are similar in all these cities, but what worked there in Melbourne, can it work in São Paulo also, or the vice versa? And so we learn from each other, and the data does tell us about the success and how we can literally tweak it. And also, it provides us it also provides to the policymakers, governments, local authorities, that they can see that there is an apparent change in what they have seen and success of C4C. For example, she just said that there's a 13% reduction in stroke. Which policymaker will not like to grab it and see that this is happening? And there are certain major data-driven policy changes which have occurred across the world. If you look at some of the IHME data and now the World Heart Observatory as well, you look in Africa, the differences in the rural and the urban areas, they have led to different kind of recommendations. You look at North America, the infographics that come from IHME are projected everywhere. You look at South America, the salt reduction programs. You look at Southeast Asia, the way the efforts have been made to curb the use of the sugar and all. Or you look at places like Asia, how the effect for various risk factor control has happened. I think that all boards and supports the observatory.
I can see how you get excited with data when it comes to data. And I know that Novartis Foundation is, I mean, they support the World Heart Observatory, they supported the report. I know you are very keen on, and you recognize the importance of data, but can you give us an example on CARDIO4Cities? How did you use data? And I'm particularly interested in what Jagat was saying, how maybe use data to discuss with decision makers, I mean, governments, and what they're looking for, and or how do you use it?
Yeah, absolutely. I think the observatory is game-changing. We need to know what we are addressing before we can plan interventions properly. And that's exactly the philosophy behind CARDIO4Cities too. You must have guessed the D stands for data. So we sit down in each of the cities and we look at the simple cascade of care for the 3 or the 4 cardiovascular risks, whether that's high blood pressure or high LDL or diabetes or obesity. How many people do you know you have in your population with hypertension? This governments know from the STEP surveys or from the World Heart Observatory. So how many of those do you then have in your system? And how many of the diagnosed in your system are treated and controlled? That's the simple cascade data. I can tell you that following that data at population level, not at individual provider level, but at population level, was new almost everywhere. So we started by setting targets. We want to have 90% of the people with an asymptomatic or with a cardiovascular risk to cure. 90% in our system, so many percent diagnosed, and let's say 30% controlled. or if they were more ambitious, 50% controlled. And that was a mindset shift for authorities to understand that they think they are doing well, but they see then that it's not really working well. And the interventions are adapted accordingly. That makes the rapid success of the cardio approach, that you redesign your interventions by periodically reviewing that data.
But another thing that I realize is you're also doing some economic evaluation, and I think that, I guess, it might have been useful in the discussion?
Yes, absolutely. So, of course, we measure everything we do. We did the whole analysis of and the modeling of the economic benefits for that. It was highly health economically efficient and highly health impactful efficient, I should say. Those both parameters were very positive, and that alone, so the number of strokes you avoid, the number of heart attacks you avoid, is a whole other cost you are saving then as a government, and that is what they wanna know. So what each government is now asking us, can you help us simulate, if I invest my million in this intervention, what is gonna be my health impact and my cost, or what is gonna be the cost if I don't invest it there? And that is the next level tools we are developing now for the CARDIO4Cities network.
Yeah, we always, I think, talk here at the summit, and we heard earlier today about the economic argument, and we always say we need to have the Minister of Finance and Economy talking about health. That will be the real changer. So hopefully next summits we can have Minister of Economy here and make the case of cardiovascular health. Talking about, I mean, other sectors, what are the key partnerships that we need to establish, Jagat, to move forward initiatives such as this, as CARDIO4Cities, and change health at the city level?
I know you are going to cut me off because
I
get too excited about various things, but still I'll give a very succinct, small little answer. Partnerships are crucial for the approaches and initiatives like CARDIO4Cities. Very ambitious, but very fruitful. Cost effectiveness is going to be immense here. They are already talking about 150 million population that they have already reached to. And this is not a small feat, right? So and again, when you look at their cardio, it is such a pregnant or a gravid term because you have got everything out there. Yes. So your intersectoral or multi-sectoral, which is the basis of this initiative, I think it is extremely important that we work with the local networks, local governments, or the regional authorities there, which bring you or allow you the depth of penetration in those areas, that allow you to have the influence, resources. They could provide you data. They can bring you the policies and regulations. For example, look at the New York City. Some of the very successful things were smoking bans in restaurants, or you talk about the ban on the trans fats there, or also providing the calories on their menus everywhere. So those are some of the most important things that you can achieve by working with the local governments. And then there are other folks, other than the policymakers, other than the governments, the health institutions, the providers, the local places, and you have successful stories like from Empath in Africa, or BRAC in Bangladesh, or for that matter, Sehat in India for telemedicine and things like that. So working with the community folks, community workers, how you can empower things, and working with CARDIO4Cities, you'll be able to provide them a better direction, data-driven direction, and a more thoughtful direction, so as to have better implementation and the likelihood of better outcomes.
So, and I hope, I mean, this partnership between WHF and CARDIO4Cities and all our members that we have here also will catalyze all these changes. So what next in terms of CARDIO4Cities, Anne? Can you share?
Yeah, Pablo. So we are creating the CARDIO4Cities Accelerator as a separate organization so that it's a standalone neutral broker between governments and our partnership. And we want to replicate CARDIO4Cities in 30 cities within 3 years, impacting the heart health of 150 million people. We are well on track. We are in 7 cities currently, engaging with 12 other cities that are going to start even this year, potentially. So we are on track. We need to get funding for the low and middle income settings, subsidy funding for settings that don't have enough resources. But the beauty of this all is that we aim to bring these 30 cities together in a CARDIO4Cities network that can foster the exchange and the learning from each other of what works well and what didn't work, that we don't have to repeat. And that being said, let me end by saying at the Novartis Foundation, we then want to go, or we are already going one step further and using the existing data in data-rich environments like New York City, Singapore, Helsinki, I just come from there, and even here in Switzerland, to bring all the data from these underlying determinants, the social, economic, environmental, air pollution, education, food sector data, everything together with the health data to see what truly drives our cardiovascular outcomes. Because we know that only 20% of our health is driven by the care we access. All the other 80% is driven by the underlying determinants. And we don't understand them well. We know a little bit about it, but we don't know what is the best or the worst combination. And I can tell you what comes out of these analytics. We've done all of the US data with our partners of Microsoft. All of the US data can predict perfectly well diabetes and hypertension in the New York population. You can pinpoint the hot zones in New York for diabetes and hypertension that is totally socioeconomically driven. So it is all about the level of education, people with high school education or less, people who have no internet access, people who need food assistance, and people over 65 who live alone are 4 determinants driving 70% of hypertension and diabetes in New York City. So these kind of results are now being integrated in the CARDIO4Cities approach to augment it to become future-proof. We will also make it fully digitized, and we wanted to use in certain countries the genomic data, the omics, the biobank data to become always more performant. So that's the CARDIO4Cities 2.0 we aim to create together.
Excellent. So, Jagat.
This is very impressive, the 4 factors that you talked about, the not having the food stamps, 65 years social isolation of these people and things like that, and not having an internet. I mean, these are unique situations which you have identified. And it's so fulfilling, as a matter of fact. I was going to use the word exciting, which is not right word. So it's fulfilling. And I was just discussing with you the other day, like in Houston, we have this Harris County where there is Ward 3 and Ward 5. The difference of the mean survival is 23 years. I mean, these are the first generation immigrants from South America. And their lifespan is about 64 years compared to adjacent Bel Air, which is all the educated community of Houston. Most of them are either the medical workers or the university workers and things like that. Their lifespan is 87 years. So difference of 23 years in that, 31% dying of heart attacks, 16% dying of cancers, and 11% of violent deaths. I mean, why can we not make a difference here? And something like C4C, I think it empowers us, and it would be a synergistic, symbiotic relationship. And I think that we look forward to changing the world if we can.
And I think it's good to use the word exciting, because I think that many people here, we are passionate about improving cardiovascular health, and we're also passionate about finding solutions, and I think I feel the same, and I think we are feeling that excitement about the opportunities. I think we are running out of time. I'm looking at Jean-Luc. If you want, maybe if you have any question, or maybe I was going to ask Alvaro, as someone who has been working in São Paulo. Oh, sorry, I didn't see you. You can ask a question, and then Alvaro, maybe you can come and make your, share your experience in São Paulo.
Oh, great, thanks. This is a great panel, very not exciting, but inspiring or stimulating. So my name is Christine Gurria. I'm a clinician scientist. I'm actually an ER doctor in the US, but I've been doing public health and non-communicable disease research in Africa, mostly in Kenya, where I'm from, for about 10 years. So I think it's really remarkable what you've been able to accomplish, and I was just skimming your paper from Novartis. But I'm curious in terms of actualizing, getting on board the different clinics for the training, how you were able to actually accomplish that, because it sounds like you did it pretty successfully. So I'm curious, that's one, even with Pen Plus, right? That's been the challenge of getting clinics on board to implement Pen Plus. So I'm curious about that. And then sustainability. I don't think I saw that in the paper, so I'm curious, right, you came in and you did all these amazing things, but like what's happened 3 months, 6 months later? Thank you.
Thank you very much for these important questions. I will leave Alvaro answering most of them, but let me say that the whole initiative is totally run by the local government. In São Paulo, we are not involved anymore. We are still there, as we like them so much, the Brazilians, but it's totally run by the São Paulo city, and the same in Dakar. I'm going in 2 weeks to Dakar to close it up for us. It's totally run by the local government and brought to other settings. In Mongolia, we have stopped being involved already several years, and it's a national program now. But for your question of how you engage the clinics, obviously it is all done through the local system. We are not building a separate system or making a siloed data system or anything. It has to get integrated in what already exists. And for getting the whole city of São Paulo up to speed with the standardization, the clinical decision support systems, it was from the beginning, the continuous medical education was from the beginning integrated in the local city education for the whole health corps. So that was thanks to the fantastic partnerships also with the professional associations on the ground. But Alvaro, you can answer this all much better than I can.
Okay, thank you, Anne. Excellent panel. Let me just speak maybe 2 or 3 minutes in bullets. We generate scientific evidence, but at the end of the day, we don't know, or most of us, we don't know how to implement it. So the point is, what is the need for generate new evidence if you are not able to implement? So it's almost the same of not having knowledge. The second point is about results. So we are able to see in 15 months, in some of those months during the pandemics, that we're able to triple the blood pressure control in the primary care setting in São Paulo city. And São Paulo is a large city, is a complex city, and I was telling Anne, if something works there, it can be applied for the rest of the world. Certainly, with a lot of complex. That's the good part of being complex. So we are able to triple the blood pressure control and see reduction in stroke hospitalization, significant reduction in 13% and 12% reduction in coronary heart disease events, plus cost effectiveness, 785 calls per year for saving those lives in terms of stroke and coronary heart event. So let's just talk about the challenges. We faced a lot of challenges, but this is doable. The first one is about not the politics, but it takes time to speak with the government, and not federal level, not even state level, but city level. And usually they tell us, we already have this structure. And we must be careful to integrate, to assimilate, and to adapt our ideas to their existing ideas. And then there is another mistake that I was part of, and I believe that most of us were part of. We believe that we know how to suggest implementation of science. We simply don't know. This is true. And why we found that? Because the process was the co-creation. We don't do that. The co-creation means we have our ideas, we identify the roadblocks in the health system, in the health professional, in the population. So by identifying the roadblocks, we are able to propose potential solutions around the table. This is wrong. And then we started the conversation with the community. And by hearing the community, we faced that they had no idea about the risk of hypertension, They had no idea that they were supposed to have a blood pressure measurement. They had no idea about the long-term treatment and the adherence. And by having this conversation, we proposed potential solution co-created with the population. And by doing that, I believe that we were partially successful because there is room for improvement for the next year. I hope that I answered not all the questions, but at least a few of them. Thank you.
Thank you, Alvaro. Thank you. And thank you for leading that work in São Paulo. And I'm sure you're going to look, and I encourage you to look at CARDIO4Cities website, learn more about that. And I'm sure you're going to be talking with Anne, with Jagat, and Alvaro in the break to learn more about this. And looking forward to the collaboration and next steps. Thank you for being here.